me. Good afternoon, everyone, and welcome to our lunch plenary with Dr. David Williams, an internationally recognized authority on social influence in health. He is the Florence and Laura Norman Professor of Public Health and Professor of African and African American Studies and Sociology at Harvard University. He has played a national leadership role in raising awareness levels of the problem of health disparities and identifying interventions to address them. I have had the immense pleasure of hearing Dr. Williams speak several times and can tell you, you are in for a treat. He has wowed me each and every time. Before I say, please join me in welcoming Dr. Williams, I have to say this. Our team scripted me on his introduction, and I need to give you an idea of how much I adore this man. They scripted me, told me not to go off script because I would just gush all over him. I knew you would appreciate that. But please join me in welcoming David Williams to the stage and the BoardSource Leadership Forum.
Good afternoon. It's really good to be here at BoardSource. I am thankful for the kind words of introduction, and it's a wonderful opportunity to share with you some of the research and findings in the area of diversity and what we can do about it. I'm going to jump right into my presentation so we have time at the end for a talk. Effectively addressing diversity and inclusion, what we can do about it, and framing the house that racism built. I want to begin. I'm a health researcher, so I'll give a number of examples about health, but they actually apply to many other domains of society. There are, in the United States, large racial inequalities in health. I want to illustrate how complex these racial inequalities in health are by looking at national data for the United States at life expectancy at age 25. That's at age 25, how long will the average person live? Looking at data for blacks and whites. At age 25, the average white person lives 5 years longer than the average African American. However, if we look within the white population by education, there's a 6.4-year gap in health between whites who have a college degree or more education and whites who have not finished high school. Within African Americans, there's also a 5.3-year gap, which tells us something important. In addition to thinking about race, we have to think about income and education, powerful drivers of health gaps in the US, and the differences by education within each race are actually bigger than the differences by race. At the same time, there is an added burden of race. So if we go back to at age 25, how long will the average person live? Whites who are high school dropouts live 3.1 years longer than blacks who are high school dropouts. And among the college educated is a 4.2-year gap. And actually, one of the most stunning statistics I will show you today is that African Americans who live the longest, blacks with a college degree or more education, have shorter life expectancy than whites with a similar level of education, have shorter life expectancy than whites who have some years of college, have shorter life expectancy than whites who have completed high school. So these data clearly tell us there is something about income and education that matter profoundly for health, but there's something else about race that also matters even after you take income and education into account. And so researchers in the health field have been asking, could racism be a critical missing piece of the puzzle to help us understand these complex patterns of racial disparities in health? So that's why I want to talk a little bit about the house that racism built. When I say racism, I refer to an organized system, not individual beliefs, not individual behavior, but an organized system that is premised on an ideology of inferiority, that some groups are better off than others, and that leads to differences in the treatment of various groups, discrimination, whether individual or institutional. And this system is linked to the society, so that if we go back and look at the larger political, legal, economic, religious, cultural systems, all of these play a role in helping us to understand the nature and complexity of racism, and all of them have been touched and tarnished by the racism in the larger society. If I'm talking about discrimination, I think it's important to understand the differences between individual and institutional discrimination. I'll talk about both of them and how they matter for access to opportunities in American society. So let me give you an example from the West Coast. Researchers at Portland State University ask a simple question. When someone stands at a crosswalk intending to cross the street, does your race determine how long you have to wait in order to cross the street? So they took 3 black males and 3 white males, dressed them similarly, and put them at different crosswalks in Portland, Oregon, to see if there's a difference in how long you have to wait to cross the street. And they found that multiple cars were twice as likely to pass a black pedestrian waiting to cross the street, and that African Americans had to wait 32% longer to cross the street. That's individual discrimination. We're talking about what individual drivers did. Let's think of an example of institutional discrimination, again linked to waiting. If we go back to national data on the 2012 presidential election, your race determined how long you stood in line in order to cast your vote in the presidential election. You could see African Americans waited the longest, 23 minutes, Latinos 19 minutes, whites 12 minutes, for example. None of that reflected the behavior of individual precinct workers. No, it reflected a number of institutional processes linked to geography. Where did you vote? And what was the budget and space constraints at the place? What was the local administrative procedures that determined the amount of staff and the resources that were available to vote in particular places? So although it did not reflect any individual behavior, it nonetheless led to systematic and systemic differences in how long persons waited to vote. If we talk about a house that racism built in the US, there is a powerful mechanism of institutional racism that operates beneath the radar screen, and it's a driver of racial inequality in America. It's residential segregation by race and the forced removal and relocation of indigenous peoples in the US. Why is segregation so powerful? Because place, your address, your geography, where you are located, determines your access to education and high quality education, determines your access to job opportunities, determines the quality of housing and neighborhood environments, determines whether it's easy or difficult to live a healthy life in your neighborhood, determines exposure to toxins. All of these are dimensions of life that drive health and opportunity that are shaped by your zip code. In fact, 2 of America's most eminent sociologists, William Julius Wilson and Robert Sampson, studying the 171 largest cities in the US, concluded that there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. All of that has been produced by the history and legacy of segregation in the United States. And in fact, segregation is responsible for much of the racial inequality we see. I'm drawing here on the work of David Cutler, one of the country's leading economists, a professor at Harvard University. He did a national study in the US, looking at a cohort of blacks and whites making it in the labor force, using fancy econometric models I cannot even fully describe, but he's able to statistically isolate the impact of segregation. And he concludes, if we could only erase residential segregation in the US, we would completely wipe out black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhood by 2/3. Because all of these differences are rooted in place, and the opportunities linked to place in American society. And so, there are racial inequalities in socioeconomic status in the US that are quite large. Here is national data for the US from a 2016 US Census Bureau survey. And I've translated this national data on household income into a way in which you can't possibly miss the point. So I'm standardizing on the household income of whites as $1. And I'm saying for every dollar whites households earn, how much do other households earn? Asian households earn $1.23. 70% of Asians in the US are immigrants. They come to the United States with very high levels of human capital. Asians as a group have twice the level of college completion as whites, for example. More important to these data, Asian households have more persons contributing to household income. So if I did a per person measure of household of income, whites would have the highest levels of income, but Asians have more persons contributing to household income. But let's look at 3 historically disadvantaged groups in the United States. For every dollar of household incomes whites had in the year 2015, Latinos had 72 cents, Native Americans had 62 cents, and African Americans had 59 cents. What is stunning about the 59 cents figure is that it's identical to the racial gap in income in 1978. You heard me right, I did not misspeak. In 1978, black households earned 59 cents for every dollar whites earned. And in 2015, black households earned 59 cents for every dollar whites earned. Most of my students think we have made a lot more progress than that in these United States. And data on racial differences in income dramatically understate racial differences in economic resources. Because income only captures the flow of resources into the household. It tells us nothing about the economic assets and reserves that households have to cushion shortfalls of income. We get that from looking at data on wealth. And the latest census data on wealth tells us for every dollar of wealth that white households have in the United States, black households have 6 pennies and Latino households have 7 pennies. And the biggest driver of these racial differences in wealth are not savings behavior. There are no racial differences in savings behavior at equivalent levels of income. It reflects racial differences in intergenerational transfers of wealth. That is, that white households are more likely to inherit wealth when relatives die. So these racial gaps in income and in education and in wealth are not random events. They are not acts of God. They didn't just happen. They actually reflect the successful implementation of social policies where institutional mechanisms of racism have produced a truly rigged system in the United States. So I've talked about institutional racism. Let's think of examples of individual discrimination. Diva Pager, a colleague at Harvard University, went to New York City, took 2 white males, 2 black males, and 2 Latino males, dressed them similarly, and gave them identical resumes to apply for entry-level jobs in New York City. She threw a wrinkle into this experiment. She had one of each pair, 1 black, 1 white, 1 Latino, say he had served an 18-month prison sentence for cocaine possession. So he had a criminal record, and he was now out on parole. And what this study found, that it was easier for a white male with a felony conviction to get a call back for a job than a black male or Latino male whose record was clean. The resumes were identical. And Diva Pager also shows that if we only focus on callbacks, we dramatically understate the degree of discrimination that takes place, because not all of the callbacks for a job are for the job that you applied for. African Americans were systematically channeled down. That is, they applied for one job, like to be a server, and they were offered a job to be a busser, a job that was inferior in quality and in pay to the actual one that they applied for. Latinos were also channeled down, but there were cases where Latinos were also channeled up, and there were multiple cases where whites were channeled up. They were applied for a job, got a call back, offered a much better job than the one they applied for. It's just one example I wanted to give you of the persistence of high-quality scientific evidence documenting the persistence of discrimination in American life. I have been particularly interested in what experiences of discrimination, the impact they could have on health, and the experiences of which individuals are aware, to what extent do they affect health. I have created a number of measures to capture discrimination in American life. One of them is called the Everyday Discrimination Scale. It doesn't capture big experiences of discrimination, but just minor, day-to-day indignities and incivilities. Treated with less courtesy or respect than others, receiving poorer service than others, people acting as if they think you are not smart, or if they are afraid of you, as if they think you are dishonest. And just to illustrate how powerful the effects of discrimination are, I'm going to draw on the work of Dr. Tene, who was at Yale University at the time she did this work, and every line on this slide reflects a different study that she did documenting the negative effects of everyday discrimination on health. So persons who report high levels of everyday discrimination have more rapid development of subclinical heart disease as measured over 5 years by the development of coronary artery calcification. Persons who report higher levels of this everyday discrimination report higher levels of inflammation. High levels of inflammation in your blood puts you at risk for all of the chronic diseases. Persons who report higher levels of everyday discrimination have higher levels of blood pressure. Pregnant women who report everyday discrimination give birth to lower birth weight infants. A study of the elderly followed over time. Those who report higher levels of everyday discrimination have more rapid declines in cognitive function over time. A study of community residents, higher discrimination predicts poorer sleep. A study of adults followed over time. Higher everyday discrimination is an independent predictor of premature mortality. Those little indignities are actually killing people ahead of their time. And a study of black and white women, higher levels of everyday discrimination for both black and white women. Black women report higher levels, but white women who report discrimination, the effects are the same, do not have higher levels of subcutaneous fat, one type of abdominal fat, but higher levels of visceral fat. Visceral fat is the deep abdominal fat in between your internal organs that increases your risk for cardiovascular disease and other bad health outcomes. So just this slide shows the power of everyday discrimination to have negative effects adversely impacting on the health of the population. And then there's racism deeply embedded in our culture. And it's evident in negative stereotypes. It leads to implicit bias. It leads to stigma in multiple ways. We have a lot of scientific evidence of the persistence of these forms of implicit bias in American life. I'll give you one example. Dr. Kevin Schulman went to a medical convention and had physicians look at patients on a videotape. All the patients were actors. They all described the same symptoms with the identical language. They were even trained to have the same facial expression and body language as they described the symptoms. The only difference was some of the patients were black and some were white, some were male and some were female. And the study found that women and blacks systematically received poorer treatment even though they had presented the identical symptoms to 800 physicians at a medical conference. Congress, in its wisdom, voted to ask the Institute of Medicine to conduct a study. Did what happened at a medical convention with fake patients actually happen when patients go into healthcare context in the United States? I served on the Institute of Medicine's Unequal Treatment Report Committee. The report was released in 2003, and we have a lot of research since then documenting the pattern. It was called Unequal Treatment. This book documented that across virtually every therapeutic intervention in the United States, from the most simple to the most complex, blacks and other minorities receive poorer quality care and less intensive care than whites. Let me give you one example so you have a sense of the scientific evidence that we have. Dr. Knox Todd was an emergency room physician at UCLA emergency room. He asked a simple question. When a patient comes into the emergency department with a long bone fracture, that's medical speak for a broken bone in the arm or leg, does your race determine whether you get pain medication or not? And Dr. Todd found that of all the Latino patients who had been treated for a broken bone in the arm or leg in the prior year, 55% of them had gotten no pain medication compared to 26% of whites who had not gotten any pain medication. Dr. Todd was a good researcher. He said it could be something else. So statistically, he adjusted for whether this patient spoke English or not, whether they got injured on the job or not, what time they showed up at the ER, how long they spent in the ER, how severe was the fracture, and after statistically adjusting for everything else, the single biggest predictor of whether a patient got pain medication or not was that the patient was Latino. Dr. Todd moved from UCLA to Emory University in Atlanta, repeated the same study looking at blacks and whites in Atlanta, and found exactly the same thing. A black person with a broken bone in the arm or leg who shows up in an emergency room is less likely to get pain medication than a white patient. Now, folks, don't focus on pain medication. This has been documented in every area of medicine, with more studies in the area of cardiovascular disease than others. It is systematic across the board. It occurs. How do we make sense of this? How is it possible in a country with the best trained workforce, where most healthcare providers wake up every morning to do their best for all of their patients, can nonetheless produce a pattern of care that appears to be so discriminatory? The best conclusion the Institute of Medicine made back in 2003, it was unconscious or unthinking discrimination or implicit bias. Those are different terms for the same phenomenon, because social psychologists have been studying this for decades. And this is not about Americans, and it's not about white people. It's about human beings, and about how all of us process information. All of us process information by putting things into categories. That's the part of the human condition. But what happens is, if based on where we were raised, based on our socialization, based on what our society taught us, there are some in-groups and out-groups. When you meet someone from a negatively stereotyped group, my next words are important. It's an automatic process, and it's an unconscious process. And that is, you will treat that person differently. That is, you will discriminate against that person. You didn't intend to. You aren't even aware of the fact that you did it. But all it takes to trigger it is the negative stereotype of the group to which that person belongs in your head. I usually tell my students that I am a prejudiced person. I'm not necessarily racially prejudiced, but I'm prejudiced because race is not the only basis of negative stereotyping in our society. Every society has in-groups and out-groups. So if I hold negative stereotypes based on my socialization about gay people, about fat people, about women, about old people, the same processes occur. And I think of myself as a prejudiced person because I think of myself as a normal human being. And if you are a normal human being, you are probably prejudiced. In fact, national data for the United States finds that 70 to 80% of all people in the United States, of all professions, of all racial ethnic groups, have negative biases against blacks, 70 to 80%. The only exception to that is black people. And among black people, it's 30% of black people. So even 1 in 3 black people have anti-black biases, because it's not linked to the color of your skin, it's linked to what's in your head and what are the experiences you have had and what are the messages you have received as you were raised in this society. Where do these negative stereotypes come from? A group of scholars have put together a database of American culture. The books, newspaper articles, magazine articles the average college-educated American would read over their lifetime. What is beautiful about this, if you have American culture in a database, we can look at that database and say, when the word black appears in American culture, what co-occurs with it? Poor, violent, religious, lazy, cheerful, dangerous. When white occurs, wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, when female occurs, distant, warm, gentle, strong. Male, dominant, leader, logical, strong. Here are the 10 most common stereotypes in that database linked to black and white. And you can see the predominance of negative stereotypes of blacks. This has profound implication for some of what we're struggling with as a society. It means when a police officer sees a young black male and assumes he's more violent and dangerous than he is, we are not necessarily dealing with a bad cop. We may simply be looking at a normal American who is reflecting what has been deeply embedded in his mind as a result of being raised in this society. The good news is, well, let me give you the bad news first. The bad news first is that research finds in 1/3 of the time it takes to blink your eye, when you meet someone, you notice their race, age, and gender, and make a decision about, subconsciously, make a decision of whether or not that person is trustworthy. The good news is there's the divine solution. Professor Patricia Devine from the University of Wisconsin has developed a program that shows there are a number of strategies that we can learn that helps us to overcome this implicit bias. But the first step to addressing it is to acknowledge it could be me. The person who says, I'm not prejudiced, I would never do that, is perfectly set up to continue to do it. What I'm saying is, individual discrimination, institutional discrimination, and the stereotypes in our culture lead to systematic differences on a broad range of outcomes in our society. And when we look at these differences, it leads to even more stereotyping, and those stereotypes go back to reinforce the system of racism and other social institutions that have existed in the first place. What can we do about it? What would it take to be successful in diversity and inclusion? First of all, we need to be clear about what kind of diversity we are talking about and what we mean when we use the term diversity. You see, some have argued that diversity is often used by some institutions as a ploy to forestall social progress. It is a set of activities to symbolize corporate goodwill without any fundamental, meaningful change. So diversity has to be the right kind of diversity. Some people believe in snowflake diversity. We are all individuals just like snowflakes. Each person is unique, but it pays no attention on any of the institutional processes that exist. Some persons advocate segregated diversity. The Army is an example of that. It argues it's the most diverse institution in American society, but people are segregated by rank. So most of the minorities are in the lower levels of the Army. Or there's many who endorse the view of colorblind diversity. They say they don't see color, they don't see race, and it focuses on celebrating multicultural events. The kind of diversity I would want to offer you is what is called critical diversity. It's one that focuses on the equal inclusion of people from all backgrounds, paying particular attention to those who have historically experienced exclusionary practices. How do we move forward with diversity? First of all, let's keep in mind that diversity is good for the bottom line. There's a lot of scientific research. I don't have time to review it, but that research indicates that higher levels of gender and racial ethnic diversity in an organization leads to greater creativity and innovation. We also have high-quality evidence from studies of large companies in the United States that finds higher levels of racial ethnic diversity produces higher sales revenue, a larger number of customers, higher than average market share, greater profitability. So diversity is in the economic interest of institutions. So what do we do? One of the things I want to emphasize, in order to achieve diversity, it is not enough to open the doors of opportunity. You need to pay attention to pipeline issues as well and preparing people to take advantage of opportunity. Let me illustrate that with the case of medicine in the United States. What has been the result of affirmative action programs on women and minorities in the medical domain? There's good news for women. In 1965, only 6.9% of female graduating from medical school were women. And in 2010, it's 48%. Today, it's 50%. Half of medical school graduates are women today. And that is wonderful progress that needs to be celebrated as a result of the affirmative action programs implemented for women back in the 1970s. If we look at what has happened for minorities, if you look at where blacks and Latinos were in the 1960s, under 3%, today they are just above 6%. So there has been improvement, but not as dramatic as we have seen for women. Why have women been much more successful of taking advantage of the open doors of opportunity than minorities? because it's not enough to put someone at a starting line of a race. You have to give them the training so they can effectively run the race. And women were more ready to walk through the doors of opportunity than minorities were. By the way, there's an interesting thing I point out here. National data for the United States shows the group in the US that is most opposed to affirmative action are whites. Whites have been the biggest beneficiaries of affirmative action policies in the United States because those policies were for women and minorities, and most of the women who benefited were white women. Just a point to keep in mind. How much progress have we made in medicine? In 2014, there was a report from AAMC showing that there were 27 fewer black males in the first year of medical school in 2014 than there had been in 1978. In the mid-1960s, 2.9% of all practicing physicians in the US were black. In 2012, 3.8% of all practicing physicians were black. We went from 2.9 to 3.8. 5.2% are Hispanic. Again, we have made a lot less progress than most of my students think. And one of the things we need to realize is that Plato said it, there is nothing so unfair as the equal treatment of unequal people. The evidence is clear. There is dramatic inequality in the United States, and nothing so unfair as the equal treatment of unequal people. So what do we need to do? What are the strategies we can implement to be successful? We actually don't have to guess. There's a science base. Studies have documented what are the strategies that work best in diversity. One of the largest studies was done by researchers at the Harvard Business School and Harvard Sociology Department. They looked at what are the strategies from the 1970s that companies have used in achieving diversity in the US. One strategy is reducing managerial bias through diversity training and diversity evaluation. Another strategy is trying to reduce social isolation of the minorities in the workforce through mentoring and networking. A third strategy is embedding accountability, mandates, and authority through affirmative action plans and diversity committees and task force and diversity managers. And the question is, which of these strategies works best to increase diversity? Strategy 1, diversity training and evaluation, does not increase racial or gender diversity. Strategy 2 has modest effects. The strategy that has the biggest impact are the affirmative action programs, the mandatory programs with explicit authority, is most effective in increasing the proportion of women and minorities in organizations in the United States. And that was a major study of thousands of organizations across the United States. Let me give you a couple case studies of success stories in diversity. One of them is the University of Michigan. It implemented in the 80s one of the most comprehensive and successful diversity initiatives ever by a predominantly white research university. What were the keys to this success of the program? It was called the Michigan Mandate. A key to success was strong leadership from the top. That's a key to success in any good diversity program, strong leadership from the top. A second key was the university president, in addition to using the bully pulpit and making clear that diversity was a priority for him, he put together a committee to implement diversity that consisted of the second highest ranking official of every unit of the university. Typically, the academic dean of the law school, of the medical school, of the college, of the School of Public Health, of every unit of the university. So it's a group of people who had influence within their local area of domain. And third, and many would argue most importantly, he placed 1% of the university's annual budget into an escrow fund that could only be used for diversity initiatives. In other words, he put his money where his mouth was. And 1% of the university's budget is a lot of money that was allocated for special diversity programs. And Professor James Dunderstadt, the president at the time, emphasized that diversity was central to the mission of the university. Excellence and diversity went hand in hand. What were the results of this program? Minority student enrollment more than doubled in about 10 years. Marked increase in minority faculty. Graduation rates for minorities dramatically improved to be the highest among public universities in the United States. Promotion and tenure success of minority faculty became comparable to their majority colleagues, and increased appointments of minorities to leadership positions in the university. There's another lesson I want you to learn from the University of Michigan. Minority enrollment today at the University of Michigan is only half of what it was at the height of this program, because Professor Dunderstadt left his role and others took his place who were scared off by lawsuits, and there is no longer the active commitment. It makes a potential point that some of the policies have to be institutionalized so that even when a leader leaves, the results can continue. Let me give you another example. The Rooney Rule in the NFL. The National Football League in the United States had a voluntary program to increase diversity among the coaches for more than 20 years. It was a summer program where minority individuals could come to training camps of all the NFL team, gain experience by working, but it had no impact on increasing diversity among coaches. And so Johnny Cochran and a group of other lawyers said they were going to bring a class action lawsuit against the NFL. And the NFL put a committee led by Dan Rooney, who was the owner of the Pittsburgh Steelers, and that's why this rule that developed is called the Rooney Rule. And what was this rule that had a dramatic impact on diversity within the NFL? The rule did not have a coda. It just said every NFL team, before it hires a head coach or general manager, must interview at least one minority candidate. There was no requirement to hire anyone, but a requirement to interview before a decision could be made. Many teams who, when vacancies came up, knew of who they were going to hire as part of their social network because of the Rooney Rule, interviewed minority candidates and were blown away by some of their interviews. So in a matter of 3 years after the Rooney Rule was implemented, the NFL went from 1 black coach to 7 black head coaches, and in the end of the 2005 season, 3 of the 6 division titles were teams with a black coach, and we had in 2007 2 black coaches coaching teams in the Super Bowl. A dramatic example, but let me also tell you one of the keys to its success. One of the keys to its success was a watchdog group of former NFL players who monitored what the NFL did to ensure that they followed not just the letter of the law, but the spirit of the law. A couple other examples of success programs in diversity is reframing the process. This example comes from the US military. The Army, it was well documented that many of the minorities who had been nominated and sent up to be promoted to the officer ranks were not getting promoted in spite of the recommendations that had been made for them. And so the Army changed its policies. It sent a message to all the promotion boards reminding them they needed to be race and gender conscious. But more importantly, it said to them, if a candidate has been nominated for promotion and you don't follow through with the promotion, you need to document in writing the reasons why this person did not get the promotion. You had to provide written justification. Within 1 year of the implementation of that rule, it eliminated the racial gaps in promotion with the Army. Unfortunately, again, when a new general came into place who no longer followed that rule, it also went away and the disparities came back. Another strategy that has been shown to be effective, this is Dr. Purdy Vaughan Hughes' research from Columbia. When an organization makes decisions on a case-by-case basis, where each decision is isolated, you hire one candidate at a time, you don't pay attention to group characteristics. Diversity is a property of a group. And her research shows that if instead of doing case-by-case hiring, it's not always possible, but whenever possible, organizations did group hirings or cluster hirings, that alone, just hiring in a cluster, is more likely to ensure there's diversity in the pool that is selected. Another important point that I don't have time to elaborate on, successful diversity programs have to transform the organizational environment, have to transform the organizational climate, have to address support and retention issues. So if we know what works to produce diversity, what is holding us back? What is the elephant in the room why we aren't being more successful? I would argue that two big things we need to do. One is we need to raise awareness of the degree of inequality that still exists in the US. Most people, most Americans, are unaware of the inequalities I just described to you today. So one is raise awareness level. But secondly, we need to build political will. We need to successfully eliminate the empathy gap. What is the empathy gap? Come with me to 1899. W.E.B. Du Bois, a very influential social scientist of the late 19th century and early 20th century, in 1899 published a book entitled The Philadelphia Negro. In The Philadelphia Negro, he has a chapter on Negro health. He documents the pervasive racial differences that existed in health in the United States. And towards the end of the chapter, Du Bois penned these words: "The most difficult social problem in the matter of Negro health is the peculiar attitude of the nation toward the well-being of the race." And Du Bois continued, "There have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference." In other words, Du Bois said the reason why these disparities persist like this is Americans don't care. He called it the peculiar indifference. Researchers study it today and call it the empathy gap. There's a well-documented empathy gap in the United States for poor people. We don't really want to go out of the way to help poor people because we think to a large degree poverty is their own fault. The research shows there is an even bigger empathy gap for minorities. Again, we feel it's their fault. They have had every opportunity. There's no need to do anything about it. Let me share with you a study published in 2014 that shows how deeply embedded the empathy gap is in American society. This study took mainly white children, age 5, age 7, age 10, and they showed them a picture of a black child being stuck by a needle and a white child being stuck by a needle. At age 5, the white children see no difference in the pain experienced by a black person who was stuck by a needle versus a white person. By age 7, there is a trend, it's very weak, but a tendency for the kids to see the white person in more pain than the black person. That's by age 7. By age 10, it's pronounced. There is a strong difference in seeing the same action being inflicted, the same amount of pain. The children see that the white person has been inflicted with much more pain. There's a lot of evidence that indicates this empathy gap that we see in this study exists in so many areas of policy, of social policy, and so many areas of acting to address racial inequalities in the United States. So one of our big challenges is we need to identify how to tell the story of the challenges of the disadvantaged in ways that resonate with the public. What would it take for a diversity campaign to be successful, for diversity initiatives to be successful? Let me summarize. Number one, leadership matters. The organization that is implementing diversity has to be clear from the very top that diversity is a priority, and it's not just rhetoric. There needs to be action backing up the rhetoric. Two, diversity must be aligned with at all levels of the organization. Yes, diversity training alone does not lead to increased numbers, but the entire organization needs diversity training. Three, it is necessary to identify and nurture a multi-sectoral core of champions. What I mean, the head of the organization doesn't have to be the only person speaking about diversity. Throughout the organization, and even champions outside of the organization need to be brought to bear so that there is the steady emphasis of information and encouragement towards diversity. Next, we need to have explicit communication strategies. We need a steady drumbeat of information. What do I mean by that? We as a people have short memories. The fact you've had a successful program once and you have raised awareness level, you cannot sit on the laurels. You need to think of regular events every month, every quarter, where you will have communication events where awareness levels are raised. Also, we need synergy that supports both recruitment initiatives as well as retention initiatives. And following the example of the University of Michigan, we need to put our money where our mouth is. There needs to be financial support for diversity initiatives. And finally, a key to success, we need to highlight interventions that are working. People are looking for success. They want to see evidence that strategies work, and we need to find examples within your organization and outside your organization that shows that change is possible, the world doesn't end, success attends change, and it's possible. So let me leave you with two quotations from two of my favorite people. Dr. Martin Luther King Jr. said, "True compassion is more than flinging a coin to a beggar, but it understands that an edifice which produces beggars needs restructuring. There are broad levels of inequalities in the United States by socioeconomic status and by race ethnicity, and it didn't just happen. We have edifices that produces beggars that need to be restructured." And finally, Robert F. Kennedy said, "Each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance." We live at a moment in American history where there are mighty walls of oppression and resistance. But each of us can be a ripple of hope, and working together, we can sweep down the mightiest walls. Thank you very much. Thank you. Thank you very much. Thank you very much. I left time, so I think we have at least 12 minutes for questions or comments. I don't know if there are microphones in the audience. I see hands, but I don't know if are there microphones? Yes, there are microphones.
Thank you for that. I have a question. How do you change mindsets around, how do you move mindsets from a zero-sum game to a growing-sum game? Because I think that's part of what's impeding progress and diversity is if another race progresses, my race somehow loses.
So that's a great question, and that's what I meant when I don't have all of the answers, but let me respond to it. That's what I meant when I said that we actually need to think of investing in research that helps us and guides us in how we tell the story of the plight of the disadvantaged in a way that connects emotionally. What research tells us is what moves people to action is not so much facts, but it's an emotional connection. And the Frameworks Institute is one organization that has done work on the topic of even addressing racial inequality and finds that there are dominant frameworks that Americans have that block them from feeling any emotional connection to the pain. And we need to talk about the issues differently than we do. Let me give you just one concrete example of the kind of thing I'm talking about. I served some years ago as a staff director for a national bipartisan commission funded by the Robert Wood Johnson Foundation called the Commission to Build a Healthy America. And one of the things we did, we got both a Democratic-leaning communication firm and a Republican-leaning communication firm. And we had them do systematic research at the beginning, trying to understand how people understood many of the health challenges in American society and what to do about it. And we were particularly sensitive to what kind of language turns Democrats off or turns Republicans off. And just to pick one example, the communications research told us that if we use language like one of the things we need to do is to level the playing field, that turned Republicans off. Because level the playing field in their mind conjured up an image of bringing some people down. But if instead we talked about language that we were creating opportunities for all and removing barriers so that everyone could succeed, both Republicans and Democrats were on board. So it's just one little example of just subtle changes in how the case is presented, and we need to do more of that kind of research around these topics. Thank you.
Hi, Dr. Williams. Thanks
Yes.
so much. Two things you said that I want to comment on. The first is the empathy gap.
Yes.
So I love this because I had not heard that before, but yet we experience it. And, you know, for those in the audience who are not African American, who often wonder why it seems that African Americans may have pleasure, which we're not, when an incident occurs to a white American, when it has been happening pervasively in Black America, it's because we feel now someone will get it fixed because it's happening to someone who they care about. And that is a part of kind of the pervasive drum beat that many African Americans experience, is that lack of understanding of how our experiences are profoundly different and pervasively worse than that of the broader community. And so when that happens in the broader community, we're not rejoicing in it, but we're feeling a sense of, oh my gosh, now someone, right, will make a difference. Sure. And then the other was the point you made about recognizing your bias. And there are many places now. I wanted to know your thought about these bias cleanses. Ohio State has one, and I actually started it 2 days ago, where they send me these emails every day about different bias cleanse activities to do. LGBT, Black, I just wanted to see what it was about in preparation for this and other things that I'm doing. So I'm interested in your thoughts about these bias. Harvard has a bias cleanse, about these bias cleanse exercises.
I was not aware of the bias cleanse exercises. However, when I talked about Professor Patricia Devine's work, I mean, there are a number of strategies that work. So for example, one of them is individuation instead of categorization. The normal human process of processing information is to put things into categories, and that's fine, but if there's a category that has a negative stereotype based on your socialization, then you will treat that category differently. Individuation means you have to take time, you have to be committed, because if you're in a hurry, bias is more likely to operate when you're in a hurry or under time pressure, because you don't have time to think about it. You go into autopilot, and autopilot will be the biases. So instead of social categorization, you do individuation, which means you stop and think and focus on the individual characteristics of this person and not on the fact that this is a middle-aged white male. Let me try to understand this person as an individual. So that's just one of the strategies. There are other strategies like stereotype replacement. You think that all women are weak. Well then, before you go to sleep tonight, just stop and imagine what a strong woman would be like. And just see in your mind's eye a strong woman. That's a stereotype replacement strategy. So there are a number of these strategies that have been shown to be effective. On the point of view of the empathy gap, one of the things that needs to take place as a society is we need to create safe places where persons of different racial backgrounds can meet and can talk where you've set the boundaries that if someone misspeaks and says something that you find offensive, that you don't dismiss that person and you don't reject the person. We all are products of our culture and society, and we need to create safe places where we can honestly have meaningful dialogue and engagement across the lines of race. Research indicates that interracial communication is stressful for most Americans, and we avoid it. And many white people avoid it because they are scared they might say something that somebody's going to get upset about, and many blacks avoid it because they think this white person is prejudiced and they don't want to be exposed to anything. And so we do need to find these safe places that can set boundaries and can foster meaningful engagement and communication, because under the skin, biologically, we are very much the same, and under the skin, socially and psychologically, we are very much the same. So we have much more in common. We are more alike than that which divides us, but we need to find safe places where we get to understand each other. And I would say to white folks, there are actually researchers who have studied the over-reporting of black friendships by white people. This is actually true. There's researchers who have documented that the average American over-reports they have black friends, and simply it is there's somebody that they work with that they say hello to at the water cooler, and they'll tell everybody this is my black friend. Never socialize together outside of work. And I'm saying it works both ways. We need to find safe places where we can talk and have meaningful dialogue and try to understand each other. I have time for one last question.
I have a black friend report. No, that's a joke. We're sitting in a highly educated room. We're in the middle of a highly educated city of Seattle. I work in Texas. I work in a small town, West Texas, Abilene. Can you touch a little bit on regional problems across America, north, south, east, west, and how we can combat that? I run a business in West Texas. I'd love to hire more African Americans. We're on a board in West Texas. We lost our one African American board member. How can we combat this regionally, especially in the South?
I think there is really, there's a tendency to think that things are a lot worse in the South. Maybe in the South, people are just more honest. I could entertain you with experiences of discrimination that I have experienced in the North and the Northeast. So I don't know. I think we are dealing with a national problem. It may be more pronounced in some areas than others, but we're dealing with a national problem. I have one last thing to tell you before I leave. It tells me I have 25 seconds. And so I want to go, can I go back to the PowerPoint slides just for 1 second? I just want to tell you the particular moment that we are living in. If someone can pull back up to the last slide where it was. If the particular moment we're living in, if you can't do it, I'll tell you in a nutshell. We need to be, as a group, as organizations working on the front lines, to be at the forefront of trying to address the challenges we face. Because there are proposals in Washington, D.C. right now to weaken the social safety net that will negatively impact marginalized groups. We don't have to guess what would happen. Ronald Reagan did it in 1982. 500,000 people lost welfare. 1 million people were dropped from food stamps. 600,000 people lost Medicaid. 250 community health centers closed across the United States. 1 million children lost reduced price school meals. The WIC program could only serve 1/3 of the people eligible, and there were massive negative effects on health. The average Medicare deductible doubled. Nationwide, more women did not receive prenatal care. 143% increase in anemia in pregnant women. The incidence of low birth weight among pregnant women in the United States. An increase in infant mortality in poor areas of 20 states. An increase in preventable childhood diseases in cities across America, and more children with high blood levels, an increase in chronic health problems among the elderly dropped from Medicaid. So folks, we are in a moment where there's work to do, and we need to think of ways in which we strengthen the safety net. Thank you so very much.